on to our next topic of concern. So, what should clinicians consider when determining whether to start treatment in a newly diagnosed patient with SMA? Talk a little bit about that.
There are many things to think about in those initial discussions. First, you may have a family who is not familiar with SMA. This may be completely new to them, to their family, and they're coming in with a seemingly healthy newborn for care, and suddenly referred to a neurologist and to a neuromuscular specialist urgently for a diagnosis that, when they hear about SMA or read about SMA, a lot of fears around, what is the future? What is the health of their child? What does that mean for motor development? And also, what does that mean for making really big decisions about treatment in a very short time span? So I think, in this care consideration document, one of the things that really came across, especially as a consensus, is that we need to think about especially the age as well as the SMN2 copy number when we're thinking especially about the urgency. And we consider urgency to treatment in all cases when we have these newborn screen call out, but especially most critically in those with the 2 copy SMN2, although again, there's urgency to treat across the board. But when we really think about those families and patients where we need to think about initiation of therapy very emergently. And these can be long discussions to make sure the family's understanding what is SMA, how did their baby come to have this, and going through the genetics of this. Also discussing what treatments exist, what are the pros and cons of those treatments, how are they delivered, how frequently, what are the side effect profile. Also, what can we start the quickest if that is, again, of highest priority, logistically or insurance or at an institution level. And then what does that look like in terms of monitoring development, outcomes, respiratory function, feeding, and things like that. So I will say that in and of itself is kind of a very nuanced, really clinic visit or visits, because sometimes we have to do that even in serial sessions to be able to make sure that that families feel that they have the time to absorb this information, read, come back to us, and really think about these critical decisions. So I would say that has really been one. It was helpful in bringing together the group in this consensus document in thinking about how we approach families and how we think about instructing or discussing the pros and cons and why a family and in a joint decision making with their clinical team may come to a decision about what therapy to initiate, but also most importantly, how quickly are we initiating that for that child?
Yeah, I really could not agree more. And to underscore a couple of the points that Diana mentioned is that rapid treatment initiation, particularly in the pediatric population, is really critical. It is based on the understanding that SMA is a progressive disease with irreversible motor neuron loss. And that motor neuron loss begins before symptoms onset. And the data showed that there is dramatic improvement with early intervention. So the best outcomes is with earlier treatment. The earlier, the better. And that's really made treatment, particularly in that patient population, an emergency. And that needs to be handled that way because time is neuron. And any delay in treatment can correlate with really worse functional outcome. Things might be less urgent, and by practice, I'm an adult neuromuscular neurologist, less urgent, but again, SMA is a progressive disease regardless of SMA type or SMA or patient age. Regardless of type or patient age, SMA is really a progressive disease. Actually, this will bring me back to a point earlier that I thought we should also highlight in terms of the changes that are happening in the field. One of the other changes that's happening in the field is how we classify SMA. And so SMA classification is evolving. Now we have treatments that are modifying or altering the natural history of the disease. And so our old way of characterizing or classifying SMA based on age of symptoms onset and maximum function attained no longer are optimal to help us characterize the outcome or the prognosis. Now we do have significant change in phenotype with those disease modifying therapies.
And I will say, in addition, at least when I'm clinically thinking about that decision tree of, how to, which therapy might be best for someone when we're thinking about newly starting a treatment. We talked about, route of administration, side effect profile. Sometimes we also, you may also look at other symptoms, baseline labs, et cetera, to try to understand, is there anything that tips your safety profile to say at this time, perhaps I should start with treatment A for various reasons, whether it's certain lab findings that exist in either screening or baseline labs. If it's not a newborn, but if it's an older individual, for example, and you're thinking about perhaps if they have more significant scoliosis, does that play into a decision making about, for example, an intrathecal treatment versus an oral therapy? What is the, what does a family or the patient think about the frequency with which they would have to take that medication as well? So it's really a kind of a multi-layered kind of decision about what works for a family, for that patient, based on the really review and thinking about safety based on some key baseline laboratory and monitoring studies that we would do. And then, kind of thinking through again, those pros and cons of the treatment approach.
I love the way, Diana, you kept saying family and you kept stressing it is family. And that's really one of the things that came also out of this document, the fact that the patient's caregiver's input together with the clinician is central to the care and it is all about the shared decision making. And so it's really important to keep that in mind.